Right, so this is Miss Manuel's Thigh, Hip, and Pelvis lecture. The information that will be presented is coming from Joel E. Beam's book on orthopedic taping, wrapping, bracing, and padding. So starting off, we'll talk about a couple of injuries and conditions. And I do want to start off by saying that you guys may not fully understand each one of these injuries and conditions because you've yet to get to your evaluation classes, but this will kind of introduce what you're seeing at these injury sites and why we are using the tape jobs that we're using, because if we don't know why we're taping, then we shouldn't be taping. We want to have a reason, we want to have a purpose before we start applying tape or braces to people, because the pull of the tape, the position of the tape could limit range of motion, or it could predispose somebody to an injury. So with the hip, our common injuries are contusions, strains, and then overuse injuries and conditions. And you can see that I have a picture located here, and this would be something that would fall under the contusion category, also referred to as a hip pointer, which is a contusion or a bruise to the iliac crest. And the iliac crest, if you put your hands sitting on your hips, it's that part where your hands would sit at. That would be your iliac crest. All right, so now we're going to dive a little bit deeper into each one of these, starting with contusions. Bruises or contusions are caused by a direct force, something impacting the body. A thigh contusion, also known as a Charlie horse, typically involves the anterior or the front and or the lateral aspect or the outside portion of the thigh. Heterotopic ossificans or myositis ossificans is the formation of bone in an atypical location, and typically that atypical location is going to be within the muscle. And we can start to get those heterotopic ossificans if we continue to have repeated stresses to a bruised area, so that bruise no longer is just to tissue. We start to get bone formation there. And this could be because we have delayed treatment, we have forceful manipulation, or we return too quickly, and like I said, have those repetitive stresses on the area. A hip pointer, which is what you saw earlier in the picture, is a iliac crest contusion, and this could be either from direct force to the hip or falling on the hip. Below, you'll see a picture of the heterotopic ossificans, so you can see in the x-ray that there's some sort of shading where there shouldn't be. You can clearly see the bone, but then you start to see the formation of something else that's outside the border of the bone, and that would be that heterotopic ossifican or the myositis ossifican. All right, so moving on to strains. Strains pertain to muscles and tendons. Sprains obtain to ligaments. So we're going to talk about strains here. Injury to the muscle can occur during any of the following: a rapid stretch, contraction, a change in direction, eccentric overload, fatigue, or muscle weakness and imbalance. A lot of the times these are very sudden. It's not something that typically you feel come on, and if you do feel something starting, we're probably already at a grade 1 and we should go ahead and hold play there. Muscle weakness and imbalance is probably going to be a big thing that you'll see with your middle school and high school athletes, especially whenever it comes to quads and hamstrings, biceps and triceps, and then core and back. Those are going to be your typical areas that you'll have to focus on when it comes to your athletes. So looking at the picture here that we have, these are your anterior muscles, or the muscles that are located on the front of the thigh that affect the hip. Some of these muscles that you'll see on your hip PowerPoint will also affect the knee range of motion. It'll cross at the joint. And so here we have our anterior muscles is going to be your quads. You'll see posterior muscles, which are your more frequent muscles, the hamstrings. The medial muscles are the ones that are located closer to the midline, or the adductors. These are collectively called adductors as a group because that muscle group helps add the hip to the body. Your posterior lateral muscles are going to be your glutes. And then iliopsoas is some more anterior muscles that are located more proximal that are known as your hip flexors. All right, so continuing with strains, we talked about hamstrings being the more commonly injured. These typically have a chronic history, chronic meaning that it's a little bit older. It's not a what we would call an acute or a new injury. Re-injuries are very common and are more severe than the initial injury. And then also, if you have an injury that's closer to the tendon, so either it's located way up high by the butt cheek or it's located way down low by the back of the knee, that's going to be more severe and it's going to take a lot longer to heal because the tendons don't have as much blood flow as the belly of the muscle. That's why our tendons are white, and that's why that belly of that muscle is more red. So here you can see that we have the lateral muscle group. So you'll see some glutes. You'll be able to see some of the more anterolateral muscles, like the vastus lateralis and the biceps femoris, which is a posterior muscle. And then you can also see the posterior muscles, some more glutes, even a little bit of the adductors, and then the hamstring muscle group there. Make sure that you know your anatomy pictures for your quiz. All of your anatomy pictures and your labeling pictures for your quizzes will come from your PowerPoint. All right, so moving on to overuse injuries and conditions. A lot of the problems with these overuse injuries is, of course, overuse, overtraining, but also because there's some type of structural abnormality. So if things aren't working the way that they should, they're going to get overused pretty quickly, or they're going to wear in a position that they shouldn't be. In addition to that, repetitive stresses, training errors, leg length discrepancies, and then an increased Q angle. So a Q angle is going to be the angle formed between the line of force from the quad to the patella tendon. Women typically have a wider Q angle than men. This is why women are more predisposed to ACL tears than men are, is because of an increased Q angle. It's also why we are a little bit more predisposed to hip injuries as well, because we have an increased Q angle. Those childbearing hips, I guess. Injuries and conditions related to some overuse could be the greater trochanter bursitis. So bursitis is the inflammation of a bursa sac, and a bursa sac is located in all different joints of our bodies, and it is a fluid-filled sac that helps provide lubrication to an area. So when those bursa sacs either get rubbed on, like increased friction from rubbing on a bone, direct force, it can cause irritation and it can cause inflammation. So with a greater trochanter, inflammation of the bursa sac there, this is usually caused by an increased Q angle. And because of that increased Q angle, it could cause more friction on the greater trochanter, which is a landmark on the femur of that bursa sac rubbing on that bone, or it could be from direct force, either by falling or getting hit. Osteitis pubis is going to be chronic inflammation of the symphysis pubis. So if you look in the picture that I have in the corner, the pubic symphysis, or the symphysis pubis, is located right in the middle where the pelvis sort of connects. It is almost like a transparent piece that you'll see on skeletons to show you that area. And sometimes your patients or your athletes may need this area, quote unquote, popped, and it'll help relieve some of that tension. But some inflammation problems can cause from repetitive tension from the adductor muscles. So the adductor muscles attach to this area here. So tension on those can pull it down. It can also cause, like if one side is tighter than the other, it can also cause some twisting or some shifting of one side versus the other, putting that area in a bind or in tension. And then we have stress fractures to the femur, the hip, or the pelvis. This could be from overload, training errors, amenorrhea, which is an absence of menstruation, oligomenorrhea, which is infrequent menstruation. So not so much that it's they don't have a period very often, but it's that the times between their periods are a little bit longer. So typically your cycle is about 28 days. A lot of women will fluctuate anywhere from 28 to 32 days. Oligamenorrhea is going to be 35 days or more between periods. And then disordered eating. So this could be anorexia, bulimia, any of those things that fall under disordered eating. All right, so we're going to talk about the strain wraps. So we'll go through these rather quickly, and then I would like for you to come back and practice them. If we don't get to discuss in person these, then when we come back the next day, we will cover these wraps, just depending on what kind of situation we're in. So the first one is going to be the quadriceps strain wrap. So the strain, we're dealing with muscles in this particular instance, the quadriceps, which are the anterior muscle group. So the purpose of this wrap, remember we always want to have a purpose when we're applying, taping, bracing, any type of technique to the person, is to provide compression to the area, to the strain. Compression is going to help the area feel better. It's going to help the muscle function a little bit better. In the event that they have a strain, if we try and compress a very healthy muscle, it'll be almost like suffocating the muscle. We can anchor padding using an ACE wrap. So if we need to make, for instance, a donut pad where you cut a circle and then in the middle of that circle you cut a hole and put it over a bruised area, we can secure that donut pad with ACE wrap. This will help the pad take majority of the blow instead of having repetitive injury to the same bruised area, and hopefully we can avoid those heterotopic ossificans. So with this, we're going to use a 4 or a 6 inch. So that's going to be the height of the wrap. Single elastic wrap. And when we're talking about wraps, we'll have singles and we'll have doubles. Singles are going to be about 5 yards. Doubles are going to be anywhere from 10 to 11 yards. So we're going a very short distance. We always want to wrap distal to proximal to help with blood flow and lymphatic flow. So we want to use a single so that we don't have a ton of bandage left over and have to come back down or have to tie it off. So a 4 or 6 inch single elastic wrap for this tape job. For your position, you're going to use a heel lift, which is going to be anything that is going to ultimately lift the heel up off the floor. So this could be anything. This could be a roll of tape. This could be a doorstop. This could be, literally anything, a roll of ribbon, doesn't matter. And you're going to have your athlete or your patient with the majority of their weight on their uninvolved leg or the non-involved leg. Okay, so we're going to anchor the wrap on the lateral side of the leg, and we're going to pull from the lateral side to the medial side, and we're going to continue to encircle the leg, wrapping by about half. So this means every time that you go around with your elastic bandage, you should go over about half of the wrap that's already on the leg. We're going to continue to wrap distal to proximal, so from the knee to the hip, lateral to medial, so from the outside to the inside, and continue to go up. Once we get to the end of our wrap, we'll secure it with a clip, and then we're going to use power flex and go in the same direction to help secure that wrap. Okay, so now we have the hamstring wrap. So now we're talking about the posterior muscles. Whenever you are wrapping your athlete or your patient, you can choose to be behind them or you could choose to be in front of them. I'm going to talk about the athlete from the front so that we are always talking in anatomical position. So again, you'll need a 4 or a 6 inch single wrap. Again, we don't have very much room to cover, so we want a single wrap versus a double. We always want to wrap distal to proximal. So now, instead of going from lateral to medial, we're going to anchor our wrap on the medial or the inside of the thigh and pull lateral to the outside of the leg. Okay, and every time we come around, we're just going to give a little tug on that hamstring. So you can see on the first picture where that arrow is, we're going to give a little tug as we wrap back around the front of the leg. So this is the same technique as the quad, except our direction has flipped. You're going to continue to wrap medial to lateral, distal to proximal till we get to the top of the leg. We can secure it with a clip and then go over it with 3-inch power flex to help secure it. All right. So now we're getting to the adductor strain wrap. So the adductor is the group of muscles that's located on the medial side of the leg. So this would be the anterior of the leg. These muscles are very tiny and very long. therefore you can get a lot of tension in them. When you are evaluating somebody with an adductor strain wrap, sometimes it can be very difficult to distinguish if we are talking about like vastus medialis, or if we're talking about a hamstring muscle, or if we're on the adductors. So making sure that we really palpate, and this could be a little awkward if you are just learning to do this for the first time, but that's okay. That's why we're here to learn. You want to put them in positions that may isolate other muscles or isolate that muscle to see if the pain goes away or if the pain gets worse. And these are all tips and tricks that you're going to learn when you get to your evaluation class. Right now, we're just going to focus on the anatomy. So here we're going to use a 4 or a 6-inch double wrap. And the reason we want to move to a double is because in the picture you can see that we're going to be going around the hip. We're going to go around the hip at least twice, so this is going to take a good bit of wrap, and then we need to come back down to the leg. So with the adductor, you're going to have the person standing on that heel lift with the majority of their weight on their non-involved leg. With the involved leg, it's going to be in slight internal rotation. So you can see in the first picture, the knee is aimed towards the inside of the body, and so the toe is aimed towards the inside of the body. And so this is going to put them in the position to try and relax those adductor muscles so we can go ahead and get them wrapped up. So you're going to start closer to the knee. So we're starting a little bit, you're going to start about mid-thigh versus closer to the knee. So mid-thigh on the lateral side, pulling towards the medial side. Once you're going to get higher up, close to the inferior hip bones, you're going to make your way around the hip as you see in picture 3. And you're going to come back down making a spica. And what I mean by a spica is in picture 4, you can see where the very top of the wrap makes that point. And that's what we call a spica. And then we'll come around the leg and back around the hip. And I know that this is very hard for me to explain in literature, so please make sure that you are watching your videos as well. We always want to wrap distal or proximal. Even in this situation, once we get one wrap around the leg, we want to refrain from coming back down to the knee. So we'll secure it at the top of the hip. You always want to finish on the leg. You never want to secure a wrap like around their back or on the actual hip. We always want to secure it on the leg. And then we can follow the pathway with 3-inch power flex. So we would start on the lateral side to go medial around the hip, making sure that we grab that clip. All right, and now the hip flexor. This would be your final wrap for the hip. Again, a 4 or a 6-inch double. So this would be the longer ace wrap or elastic wrap. And it's going to follow the same protocol as our hip adductor, but we are changing directions, because when we're going to change direction, you can see looking at these arrows, the second arrow from the bottom, you can see how that arrow moves up towards the opposite side of the hip. So when your wrap is going to come around there and go up, it's going to assist in hip flexion, which is what we want to do. We want to assist in hip flexion so those hip flexors kind of have a spring and don't have to work as hard. So looking at the protocol here, we're having them stand on that heel lift. We want them in a neutral position, unlike the adductor wrap. And we're going to start mid-thigh as we did before with the adductor wrap, but we're starting on the medial side now, pulling towards the lateral side. And when we're going to get to those inferior hip bones, we're going to go ahead and go around the top of the pelvis, the low back, and circle back around. So on picture number 3, when we are pulling that ace wrap up, that's where we're assisting in that hip flexion. So what else can we use some of these wraps for? Let's talk about a thigh compression wrap. So this controls mild to moderate swelling. So again, nothing super severe with a mild thigh contusion or a strain. So this could be very similar to a hamstring or quadriceps strain wrap. We can anchor padding with this. We want to use a single elastic wrap, and we always want to wrap distal to proximal. Reason we want to wrap distal to proximal is that we don't want to milk any of that swelling down into the low leg, into the toes, because it has nowhere to go. We want to push it up, let it circulate throughout the body. Hip pointer tape or wrap, this is going to help absorb shock and prevent or help treat contusions. So this is something that we could use for our athletes that we know are going to be predisposed, such as football players, to getting those hip pointers. We can anchor padding there for them. A donut pad really wouldn't help much in this instance because of the large area that we have to cover. So we would use something a little bit larger. When you're using elasticon, you can anchor it to the abdomen over the padding and on the end of the back. And then we can use an elastic wrap to secure it to the hip area and secure with power flex as well. All right, so sleeves and bracing. The thing about ace wraps and sleeves is that we can wash those and reuse those. So it's super great that we have versatility with these wraps as well as continued use with them. So with a thigh compression sleeve, this is going to help control some swelling as well, and the individual can apply it themselves. It's like a sock without the end of it. So they could just slip it on themselves, they can take it off, they can wash it, they can rewear it. Now, it may loosen up over time. As with an ace bandage, you can apply the tension as you would like. A neoprene sleeve, this is going to be a little bit tighter than the thigh compression sleeve, which is usually made out of cotton. You can stretch and stretch and stretch those cotton sleeves probably until they rip. These neoprene sleeves are going to be a little bit tighter, but again, the athlete can apply it themselves. They can wash it and then wear it themselves again. Neoprene shorts, this is still going to provide some compression and mild support when we're treating different types of hip injuries like strains, contusions, or some overuse injuries. Now, the thing with overuse injuries is that we need to find out why that was injured. We can't just slap on a treatment and a pair of shorts and then send them back out. We need to try and fix the abnormality if that's what's causing the overuse, and go from there. A thigh, hip, and pelvis combination brace. This can help in multiple aspects. It will treat all hip muscle strains, so whether it is, excuse me, anterior, posterior, adductors, or lateral muscles. And while it provides compression and mild support, but it also limits range of motion, which is going to help to treat those muscle strains. If the muscle can't move throughout its full range of motion, the fibers aren't contracting or stretching in its full range of motion, therefore it's limiting it to help it heal. And then the last thing is padding. We talked a little bit about it previously, how we can attach it with ace bandages or with elasticon. So some of the purposes is going to be to absorb shock, provide protection, prevent and treat. It says quad and iliac crest contusions because those are the most common, but we can use this in other areas. It's also going to help with those myositis ossificans. Some, depending on the sport, and some associations require that like mandatory padding. You must have pads in certain areas. So the NCAA and the NFHS, those require mandatory padding for certain sports and for certain areas of the body. For example, for football, I don't know how many times the referee has to tell the players to pull those knee pads down. They have to be over your knees. There's a reason for that. Patella fractures, thigh contusions, pull those thigh pads down. We want to make sure that you have the protective padding because you are in a predisposed environment. The purpose is for you to get tackled. So making sure that we help limit as much of those injuries as possible is definitely a plus, especially when it's built into the uniform and it's a mandatory padding for the particular sport. This is the last slide in the slideshow. So from here, we would conclude with our lab and then studying for our quiz.